Hello, I am Dr. Nasmani, and in this session I am dealing with the topic acute respiratory distress syndrome. The history of ARDS. It was first recognized during the 1960s, so it's around more than 60 years since the entity has been recognized. Military doctors in Vietnam called it as a shock lung, and civilian doctors call it adult respiratory distress syndrome, and now the term is acute respiratory distress syndrome. Definitions. In 1994, the American European Consensus Conference on ARDS defined both ALI and ARDS. ALI, or acute lung injury, acute onset of bilateral infiltration consistent with pulmonary edema, but without evidence of elevated left atrial pressure, is the prerequisite for ALI and ARDS. The pulmonary capillary wedge pressure is equal to or less than 18 mmHg if it is measured. This part is also very important. The degree of hypoxemia differentiates ALI and ARDS. ALI, in this ratio of the arterial oxygen tension to fraction of inspired oxygen, that is PaO2 divided by FiO2, is equal to 201 to 300 mmHg. In ARDS, it is PaO2 divided by FiO2 equal to or less than 200 mmHg. Epidemiology of ARDS. In a multicenter population-based prospective cohort study in the United States, the reference is given below. The study followed more than 1,100 patients with ALI or ARDS over 15 months from 1999. The prevalence was around 86 per 100,000 persons per person years for ALI and 64 per 100,000 persons years for ARDS. I thank the reference indicated below. Pathophysiology. Healthy lungs regulate the movement of fluid to maintain a small amount of interstitial fluid and dry alveoli. This is interrupted by lung injury, causing excess fluid in both the interstitium and alveoli. Consequences are impaired gas exchange, decreased compliance, and increased pulmonary artery pressure. So there is excess fluid in both the interstitium and alveoli, causing poor gas exchange, lung compliance decreases, and pulmonary artery pressure increases. The normal pulmonary capillary endothelium is selectively permeable. Fluid crosses the membrane under the control of hydrostatic and oncotic force. Serum protein remain intravascular. And there's a figure showing the Starling's forces, about which just now I told. The net movement depends on the difference between PC and pi c. The forces are towards the interstitium in the arterial end and into the vessel at the venous end of the capillary, and this causes water movement from the arterial end of the capillary into the interstitium and into the venous end of the capillary, into the venous end of the capillary, at the venous end of the capillary. Balance of hydrostatic and oncotic forces normally allows small quantity of fluid into the interstitium, but the three mechanisms prevent alveolar edema. Retained intravascular protein maintains an oncotic gradient favoring reabsorption. The interstitial lymphatics can return large quantity of fluid into circulation, and the tight junction between the alveolar epithelial cells prevent leakage into the air spaces. So these are the three things about which I said: intravascular protein, lymphatics, and tight junctions. Injury. In acute lung injury and ARDS, there is alveolar injury, there is diffuse alveolar damage. The injury causes release of pro-inflammatory cytokines, tumor necrosis factor, interleukin 1, 6 and IL-8 are released. These cytokines recruit neutrophils to the lungs, where they become activated and release toxic mediators, that is reactive oxygen species and proteases, that damage the capillary endothelium and alveolar epithelium. The picture shows the diffuse alveolar damage. Hyper photomicrograph shows changes typical of the proliferatory or later stage of diffuse alveolar damage. Although hyaline membranes are still identifiable, the histologic picture is now dominated by thickening and reorganization of interstitial structures due mainly to marked proliferation of mesenchymal spindle cells, including both fibroblast and myofibroblast. Damage to the capillary endothelium and alveolar epithelium allows protein to escape from the vascular space. The oncotic gradient that favors resorption of fluid is lost. The fluid pours into the interstitium. The result is air space filled with the bloody proteinaceous edema fluid, debris from degenerating cell, functional surfactant is lost, alveoli collapse. Consequences are impairment of gas exchange, decrease in lung compliance, increased pulmonary arterial pressure, about which I told just now. Impaired gas exchange primarily due to ventilation perfusion mismatching. Physiologic shunting causes hypoxemia. Increased physiologic dead space impairs carbon dioxide elimination. A high minute volume is generally needed to maintain a normal arterial carbon dioxide tension PaCO2. Hypercapnia is uncommon. Decreased lung compliance. Decreased pulmonary compliance is one of the hallmark of ALI and ARDS. Pulmonary hypertension. Pulmonary hypertension occurs in up to 25% of the patients with ALI ARDS who undergo mechanical ventilation. Pulmonary hypertension is associated with an increased risk of death. Pulmonary hypertension, the causes are hypoxic vasoconstriction, vascular compression by positive airway pressure, parenchymal destruction, airway collapse, hypercarbia, and pulmonary vasoconstriction. Pathologic stages: exudative stage, proliferative stage, and fibrotic stage. There are three pathologic stages: exudative, proliferative, and fibrotic. In exudative stage, diffuse alveolar damage is there. After 7 to 10 days, proliferative stage develops. Pulmonary edema, proliferation of type 2 alveolar cells, squamous metaplasia, interstitial infiltration by myofibroblast, early deposition of collagen. In fibrotic stage, characterized by obliteration of normal lung architecture, diffuse fibrosis, and cyst formation. Time course of ARDS is shown in this graph. During the early or exudative phase, the lesion is characterized by hypermeability, pulmonary edema followed by formation of hyaline membrane. After 7 to 10 days, a proliferative phase may develop with marked interstitial inflammation, fibrosis, and disordered healing. Etiological and predisposing factors: sepsis, aspiration, pneumonia, severe trauma, massive transfusion related ALI, TRALI, lung and hematopoietic stem cell transplantation, drugs and alcohol, example aspirin, cocaine, opium, phenothiazine, and tricyclic antidepressants. Practical problems: during the determining the PaO2, FiO2 requires arterial blood gas ABG analysis. However, arterial blood can be difficult to obtain from some patients. Poking the artery again and again is not that easy, especially in children. For such patients, a ratio of the oxyhemoglobin saturation measured by pulse oximetry SpO2 to FiO2 is a reasonable substitute. According to a retrospective study of ABG measurement performed in adult receiving mechanical ventilation. I thank the reference shown down for this part of the presentation. The study found that SpO2 by FiO2 235 predicted a PaO2 FiO2 of 200, the threshold for ARDS, with a sensitivity 85% and specificity 85%. SpO2 FiO2 of 315 patients predicted a PaO2 FiO2 of 300, the threshold for ALI, with a sensitivity 91% and specificity 56%. Course of ARDS. Initial course. The initial features of ALI ARDS are due to both the precipitant, fever, hypotension, and in a patient with sepsis, and the respiratory dysfunction. Pulmonary abnormalities typically develop within second or third day of the inciting event and rapidly worsen. Clinical findings are dyspnea, tachypnea, hypoxia, high concentration of supplemental oxygen are required, dry cough and chest pain. Physical examination shows tachycardia, cyanosis, tachypnea, and diffuse rails. Mechanical ventilation is almost universally required. Arterial blood gases: acute respiratory alkalosis, hypoxia, elevated alveolar arterial oxygen gradient. The laboratory features are leukocytosis, DIC, lactic acidosis. Initial chest X-ray typically has bilateral alveolar infiltrate, while computed tomography reveals patchy abnormalities that are more dense in dependent lung zones. The chest X-ray showing diffuse bilateral alveolar infiltrate without cardiomegaly in a patient with ARDS is shown here. It's an example of an adult. And this is the CT scan of a patient with ARDS and pneumococcal pneumonia. Subsequent course: patients who survive the initial period exhibit better oxygenation over the next few days. Decrease in alveolar infiltrate on the chest X-ray. Less ventilatory support may be required and weaning may begin. Less lucky people: some patients have persistent ventilator dependence and complications. Increase in airway pressure. Progressive pulmonary hypertension, development of honeycombing on chest X-ray, persistent interstitial infiltrate in X-ray and CT, organization of fibrosis, which is shown in this pathology. Complications may be related to prolonged ventilation like pulmonary barotrauma and nosocomial pneumonia. Critical illness and being in the ICU may lead to deep vein thrombosis, gastrointestinal bleeding, due to stress, poor nutrition, side effects from the medications, and also catheter related infections. So the diagnosis is actually diagnosis by exclusion. Other cause of acute bilateral infiltrate, severe hypoxia and respiratory distress have to be excluded. Cardiogenic pulmonary edema, the measurement of plasma brain natriuretic peptide level, echocardiography and right heart catheterization are needed in some cases. A plasma BNP level below 100 picogram per ml favors ALI ARDS. This derives from an observational study of patients with ALI ARDS. The study found that plasma BNP level less than 100 picogram identified ALI ARDS with sensitivity 27, specificity 95%, positive predictive value 90%, and negative predictive value of 44%. Echocardiography, transthoracic echocardiography, if cardiogenic pulmonary edema cannot be excluded by clinical evaluation and measurement of the plasma BNP level. Severe aortic valve dysfunction, mitral valve dysfunction, or severe reduction in the left ventricular ejection fraction favors cardiogenic pulmonary edema. Cardiogenic pulmonary edema cannot be excluded on the basis of an echocardiogram. Diastolic dysfunction and volume overload due to acute renal failure may exist even if the left heart function appears normal. Right heart catheterization, no value to routine right heart catheterization for either the diagnosis or management of ALI and ARDS. Pulmonary artery catheterization may be considered if cardiogenic pulmonary edema cannot be excluded on the basis of the clinical evaluation, plasma BNP measurement, and echocardiogram. Cause of hypoxemic respiratory failure, bronchoscopy may be performed. Hypoxemic respiratory failure, pneumonia, diffuse alveolar hemorrhage, idiopathic acute eosinophilic pneumonia, cryptogenic organizing pneumonia, lung cancer. So to summarize, acute lung injury is defined PaO2 by FiO2 equal to 201 to 300 millimeter mercury. ARDS is equal to PaO2 by FiO2 equal to or less than 200 millimeter mercury. Respiratory findings within 48 hours are dyspnea, tachypnea, hypoxia, tachycardia, cyanosis, tachypnea, and diffuse CREPS. ABG shows acute respiratory alkalosis, hypoxemia, and elevated alveolar arterial oxygen gradient. Chest X-ray shows bilateral fluffy alveolar infiltrate. Prominent air bronchogram. Mechanical ventilation is usually required. ALI and ARDS are diagnosis by exclusion. And the severity of illness score, higher apache 3 score have an increased likelihood of death. Odds ratio 1.78 per 25 point increase. 95% confidence interval 1.16 to 2.73. Care and oxygenation in acute respiratory distress syndrome, supportive care, sedation, and paralysis of neuromuscular blockade improves the condition. Hemodynamic monitoring by central venous catheter, nutritional support is needed. Glucose control, nosocomial pneumonia, ventilator associated pneumonia may complicate. Microbiology and antibiotic use may be needed. And then hypoxia is managed by increasing the FiO2, low tidal volume ventilation, permissive hypercapnia, and open lung ventilation. Ventilation strategies are APRV and ECMO, airway pressure release ventilation, high frequency ventilation, and liquid ventilation have also some important areas of new development. Prone positioning improves oxygenation in the majority of patients. And novel therapies are beta agonist, terbutaline, surfactant, inhaled vasodilators like nitric oxide, inhaled prostacyclin, mechanical ventilation using low tidal volume like lung protective ventilation. Neutrophil elastase inhibitor, sevelastat, a reversible competitive inhibitor of neutrophil elastase. Arachidonic acid inhibitors, ketoconazole, ibuprofen, antioxidants, glutathione, lisofilin. So that is my brief attempt on acute respiratory distress syndrome and ALI. You can see the uploaded video on the channel youtube.com/AcePGMed and facebook.com/AcePGMed gives a lot of links to similar programs and videos. Thank you.